Yeah, so what we had performed was a meta-analysis of the studies looking at the benefits and harms of HCC surveillance in patients with cirrhosis. So when we take a look at this on a broader scale, we have very good data that came out of China showing that HCC surveillance was of benefit in patients with chronic hepatitis B in a large randomized control trial. We don't have similar randomized control trial data in patients with cirrhosis, and so we're forced to depend on cohort studies. And so we conducted a meta-analysis of the cohort studies that have been conducted in the last 5 to 6 year period. And we felt this was important given changing epidemiology over time, where we have more and more patients presenting with hepatitis C cure, more and more patients presenting with alcohol-related or NASH-related cirrhosis in terms of underlying etiologies. And so we looked at the association between surveillance receipt and 3 clinical outcomes to define benefits: early detection, curative treatment receipt, and reduced mortality. And we found that HCC surveillance was significantly associated with all 3 clinical benefits. Now, conversely, we also looked at potential harms of HCC surveillance, and that can include physical harms, diagnostic workup of false positive or indeterminate results, psychological harms, or financial harms. We found 4 studies that quantified the physical harms of HCC surveillance, and no studies that have looked at psychological or financial harms of HCC surveillance. The 4 studies that have looked at the potential physical harms of HCC surveillance showed that this ranged from about 8% up to 28% across the studies, with most of those harms being mild in nature. And so our conclusion was that right now the data show or suggest that HCC surveillance is of high value and should be performed in patients with cirrhosis, although we do recommend continued studies to evaluate this in emerging patient populations, most notably those with underlying NASH. Yeah, I think the first is that we need to identify those populations that are at high risk. And so right now, most guidelines agree those are, subsets of patients with chronic hepatitis B and then any patient with cirrhosis from any etiology. We know that HCC surveillance should be done on a semi-annual basis, so to do this every 6 months. And the current recommended tests are ultrasound with or without alpha-fetoprotein, depending on which sort of societal guidelines you follow. So, for example, EASL guidelines recommend ultrasound alone. The American Association for the Study of Liver Disease, the AASLD guidelines, recommend ultrasound with AFP. My current sort of suggestion is to perform ultrasound with alpha-fetoprotein because the available data suggest that the sensitivity is significantly higher using the 2 tests in combination. And then I think you have to take a look at how well those tests perform in your underlying patient population. We do know that ultrasound has poor visualization, more prone to failure in some patients, particularly those with underlying NASH and those ones with underlying obesity. And so if you learn that ultrasound does not give you good visualization, those are patients where we're looking for alternative modalities, although we're waiting for those newer emerging surveillance tests, whether those are biomarker-based or imaging-based, to be validated. So those are studies that still need to be done. Yeah, I think there's 2 things that really need to be done in terms of us improving the effectiveness of HCC surveillance. We and others have pointed out that surveillance is often underused in clinical practice, so many patients fail to receive HCC surveillance. And so the first thing is that we need to continue to work through interventions that can increase HCC surveillance as part of clinical practice. The second is our search for better tests. So right now, as I mentioned, we're doing ultrasound and AFP, but that combination misses HCC at an early stage in about 1/3 of patients. So the sensitivity of that combination is about 63-65%. So we clearly need more accurate tests, whether that, once again, is blood-based biomarkers, liquid biopsy techniques, et cetera, or if that's imaging-based techniques, such as, MRI-based surveillance. And so, we still have some work to do to validate those emerging modalities, but I think we need to work in parallel both in terms of utilization as well as new tests that can improve sensitivity.